What's up, everybody? This is Joe with 0 Hour Med Solutions, and today we're going to talk about that second step in March, airway. It is one of the other most important steps whenever you're going through your March trauma assessment. So massive hemorrhage is that top #1 most preventable cause of death across the entire world, but airway is not too far behind it. Airway obstructions are one of the top preventable causes of death in trauma. Just like massive hemorrhaging, you only have a few minutes. It is the same thing for airway. If that airway is obstructed, you only have minutes until you're going to have permanent brain damage and or death, right? You can go into respiratory arrest, which then will be followed by cardiac arrest. And it doesn't matter, again, if somebody's eyes hanging out of their socket, their legs blowing off, does not matter. If air is not going in and out, there's no oxygen being delivered to that body, there is no life sustained. Airway can be very, very simple. There's only a few steps we're going to take, especially as non-medical providers. Unless you're a paramedic, you're an ER doc, right? You're not out there criking and doing advanced airways. You're not intubating people on the side of the street. We only have a few assessments and a few interventions that we can actually perform as a non-medical provider. So let's get into the assessment for airway. The airway is very simple whenever you're assessing. Do you hear the person talking, screaming, yelling? If they're yelling at you, airway's done. If they're talking or they're able to articulate how they're hurt, where they're injured, what happened, guess what? They're moving air in and out. If that airway's obstructed, guess what? They're not going to move any air. They can't talk, all right? That's one of the key things whenever that air goes across the vocal cords to be able to talk. So if they're talking to you, airway's done, move on, go assess any other life-threatening injuries that might be present, and we're going to go ahead and continue into our respiratory. So what do we do if that patient is unconscious or we don't hear any obvious talking, screaming, yelling, or any breath sounds? So if our patient is unconscious, that just means we have to investigate a little further. And it's going to be as simple as performing an airway maneuver, so a head tilt chin lift or a jaw thrust. When people are unconscious and they're real relaxed, their muscles relax, okay? So their tongue can go back and occlude, fancy word for block, the back of the throat, that oral cavity, all right? So whenever we open that airway, we align those structures with the manual maneuver, and then that helps get the tongue off the back of the throat. Performing an airway maneuver is also awesome because what it does is allows us to visualize the inside of that mouth. There's a few things we're looking for when you're visualizing the inside of the mouth. We're gonna look for any vomit, blood, broken teeth, foreign objects, whether solid or liquid, and we have to clear it. If we don't see anything, cool, we're good to go. We're gonna move on to either another basic airway adjunct, such as a nasopharyngeal airway, also known as an NPA. There's things called oral pharyngeal airways, OPAs, but outside of those basic airway adjuncts, there's not a lot we're gonna do, again, as a non-medical provider. So what do you do whenever you're observing somebody's airway? You perform a manual airway maneuver and you do find something, whether liquid or solid, in that person's mouth. If we find anything and it's a liquid, guess what? Unless you're a paramedic, again, or a doctor, you're probably not walking around with suction to be able to clear that airway. So that means we have to roll them and we're gonna let gravity assist us. So that means we're gonna roll them over in the recovery position. When we put them in that recovery position, it allows their head and mouth to hang down to the side, facing downwards, so gravity can help pull that blood, vomit, whatever fluid it is, out and onto the ground instead of going back into the throat, potentially being aspirated, so inhaled into their airway, or sitting in the back of the throat, blocking that path for air to move. So what if it is a solid object? If it's a solid object, we're gonna go in and do a finger sweep. We can use whatever finger you want, but we're not going to do blind finger sweeps. Blind finger sweeps have the potential to make things get lodged in even farther, and if we see anything but we can't easily grab it or remove it, we're also not going to try to go in there and finger sweep it out. Now, if you can see it, it's easily retrievable, absolutely go in there, remove that solid object, and that will help ensure they aren't choking on it later on, and then potentially let it move down to where it can obstruct that airway. So when we're talking about airway, it's good to know a little bit of the anatomy of that airway. So we have a couple different spaces in that airway, such as the nasopharyngeal space, the oral pharyngeal space, and the pharynx where they meet at the back of the throat that goes down into your respiratory tract. The key here is to make sure that oral pharyngeal space, again, is cleared from any solids or liquid obstructions. And then same thing for the nasal cavity or that nasopharyngeal space. That is awesome to make sure we can maintain a patent airway. And the way we do that is by using tools such as a nasopharyngeal airway. The nasopharyngeal airway is just simply a tube. It's curved to fit the curvature of the face. It has a little beveled side on one end and has a little flange or flared side on the other. All this does is ensures that we maintain a patent airway even when they're unconscious, and it allows us to move on and continue the rest of our trauma assessment instead of having to sit there and manually do an airway maneuver, ensuring that we keep the airway open. This helps do this for us. Nasopharyngeal airway, just like any other intervention we do throughout our March trauma assessment, we cannot forget that we have placed it, okay? Because things can become non-effective, okay? They can stop working. So just like bleeding control, if you put on a tourniquet or pack a wound, forget about it, you move that patient, don't reassess, guess what? They can start bleeding out and die very quickly. It's the same thing with the airway. If we insert a airway adjunct like an NPA and we forget about it, and at some point they stop breathing during the rest of our March trauma assessment, but we don't go reassess, manually open that airway, they're going to die. It only takes 5 to 6 minutes without oxygen to that brain for that brain to sustain some type of permanent damage and or death, respiratory arrest, cardiac arrest, and so forth, right? It's like a cascade of effects. So always make sure we know our patient status. We do frequent reassessments, and then if this is indicated and you are properly trained, then go ahead and insert that if they're unconscious, and that way you can know your airway's patent, maintained, you can continue with your March trauma assessment. All right, so for our NPAs, how do we insert them? There's a few steps. First, we have to make sure we have the right size NPA. How we measure is we're gonna measure from that nair, so the side of the opening of that nose, over to the bottom of that ear lobe. If it's at least that long, then we know it is long enough to go through their nasal structures, proportionately to their body, and then bypass that tongue and that oral pharyngeal airway. The most common size NPA you're gonna see is probably a 28 French. That's gonna fit most males and females. Now, obviously, when you get into very large people or very small females, it's gonna change a little bit. So having a varying sizes, I usually carry about 3 different sizes, and that can get me through most patients if I do need it. So I'll show you how we measure. As you see, we have the patient's nair right here. We're gonna put that NPA, we're gonna touch it on the side of that nair and take it over to their earlobe. Now you see how that fits perfectly? That means we know it is the right length. Once we have it measured, we know it's ready to go. We can go ahead and insert this. But before we insert, we need to put some type of lubricant on it, all right? So in the Marine Corps, we like to commit human rights violations. I'm obviously joking, okay? Don't go get me, Marine Corps. But we'd make our students practice on each other, and a lot of times, whenever you're inserting it, we'd make them put it in each other's mouth, get spit on it. We'd use it as our lubricant, all right? Now, in real life, are we gonna do that? Absolutely not. If you have to and you have no other option, there might be a potential for it, okay? But a lot of these NPAs come in a pre-lubricated package, so they're already lubricated with a water-based lubricant jelly, so that way you can insert them in and they'll just slide right in straight out of the package. So if they don't come in a pre-lubricated package, a lot of times you can get those little water-based lubricant jelly packs. They're very small, they're very easy. You can get rubber bands, rubber band it to the outside of your package, get a piece of tape, tape it to your package, or keep them somewhere in like more of an admin or Band-Aid type pouch in your med kit. Throw them in there, have them readily available. That way you can lube up your NPA and then it's good to insert. So when we're inserting our NPA finally, whenever you're inserting it, usually most people want to put it in that right nostril. That's because a lot of times that tends to be anatomically a little bit larger on most people than that left nostril. With that being said, you can insert it in either nostril. Whenever you're looking at an NPA, it's going to have what's called a bevel side. As you see, it's slanted right here. That bevel side that's open and slanted, that's going to always go towards that center line of the nose, towards that septum. The reason we use the bevel towards the septum is because you have those cartilage and structures. That bevel on that angled side just helps the NPA slide over and past those structures and just makes the process a lot smoother. Whenever you're prepared to insert that NPA, you do not go up that nasal passage, all right? There's nothing up there. The nasal passage goes almost straight back and just down. So if you're trying to shove it up their nose, you're probably just gonna give them a nosebleed. You're just gonna be hitting all that soft tissue in there in that soft mucous membrane area, and you're not gonna go anywhere, all right? So you have to put it back. That nasal passage goes almost at a 90-degree angle, just straight back. So if you're sitting there and they're laying on the ground, you're gonna insert this almost straight down, and I do what's called pigging their nose. So if I'm inserting this in a patient, I'm gonna put my thumb in that nose, I'm gonna pig it, open it, so I can visualize that airway and insert it straight back and down. So remember, when we're inserting the NPA, we have to measure it from the nair to the ear, make sure it is the correct length. We have to lubricate it, then we have to insert this pretty much straight down and back in that nasal passage, But then we also have to have that bevel facing that center line, right? That septum of the nose. Then we're gonna pig that nose, and then I'm gonna insert that NPA straight back and down, and I'm just gonna go insert, insert, insert until it is seated flush on that person's nose, all right? Once it is inserted, we have to go in there and visually assess that placement to make sure it is placed in the correct location or it didn't get bent in half and it's just all jammed up in somebody's nasal passage. So what we're gonna do is do our airway maneuver again, either a head tilt chin lift or a jaw thrust, and we're gonna visually inspect that person's airway. You should see that NPA down in the back of the throat. You will see it, especially if it is long enough and you measured it correctly, okay? That's how we verify placement. And then we're gonna do a quick look, listen, feel. Whenever we're doing our look, listen, feel, all we're doing is looking for placement. We are listening for breath sounds, and then we can put our hands on their chest and just ensure that we feel chest rise and fall. That just tells us the breathing. If their chest is rising and falling, we know our placement's good, we know the breathing, and so now we know they have an NPA and they have a patent basic airway adjunct, so we can move on the rest of our March trauma assessment. So let's do a quick recap of airway. If somebody's awake, alert, conscious, screaming at you, you can hear air moving, obviously, because they're talking or screaming. Airway's done, move on to respiratory of the March trauma assessment. If your patient is unconscious, we're going to conduct our manual airway maneuvers, head tilt, chin lift, or jaw thrust, visualize that airway, clear any liquid or solid foreign objects if we see any. Once we clear the airway, we're going to go ahead and insert a nasopharyngeal airway if properly trained and if they are unconscious and it is indicated. For inserting your NPA, one, you have to measure nair to the earlobe. You have to lubricate it. You're going to insert it straight 90-degree angle to the face, down and back, all the way up to that flange on your NPA. And that bevel is going to be facing that septum or center line of the nose. After we insert, we're going to visually confirm placement and ensure that patient is breathing with our look, listen, and feel acronym. And then airway's good, and we're moving on to respiratory of the March trauma assessment. Hopefully y'all learned some new information in today's video. We just wanted to give a quick rundown of the A of the March trauma assessment. If you did learn anything, let us know in the comments below. What did you learn? What is new for you? Also, drop us a comment if you ever inserted an NPA. And did you do it in training? Were they awake? How did that go for that person? Were they coughing and gagging? Did you give them a nosebleed? Or did you insert it nice, smooth, and effectively? Or was the patient a real trauma patient? Did you insert the NPA and did it work for you? Again, my name is Joe with 0 Hour Med Solutions. Thank you for watching. If you want to go pick up any gear, training, or merch, you can go to our website that is linked in the description below, and we'll see you in the next video.